Hi, my name is Jeff Walline. I'm the Associate Dean for Research at the Ohio State University College of Optometry, and I'm here to talk to you about myopia control. Before I do so, I want to give you a little bit of background about me, just so you know where sort of my experience comes from and my expertise. I've conducted several studies, beginning with my PhD dissertation on myopia control in children. We've conducted studies using alignment fit gas permeable contact lenses, ortho-keratology contact lenses, and soft multifocal contact lenses. And I'm also mentoring somebody who's conducting a study looking at sort of the combined effect of soft multifocal contact lenses and low concentration atropine. So it's from those, also from a clinic that I started for sort of pediatric contact lenses, which of course became primarily myopia control, that I have some experience in fitting kids with these various modalities, and also sort of looking at the literature and assimilating some of the findings from our own studies to talk to you about myopia control. So it's that with that information that I am going to provide you with what I hope you need for clinical practice in order to be able to practice myopia control on your patients. Before I begin, though, I do want to let you know that I do receive research materials. We receive contact lens solutions from Bausch & Lomb. We use these solutions for a federally funded myopia control study using soft multifocal contact lenses. Myopia control is very important today. I think part of it has to do with the rising prevalence, but also part of it has to do with the internet. People are just much more informed, and they're asking about what they can do to try to keep their children from becoming as nearsighted as they are themselves. Because of that, we need to know more about myopia control. And that's what I hope to be able to impart to you today, is give you that background so that you can talk to patients about the best forms of myopia control, forms that don't work so well, and be able to provide them with an informed ability to make a decision about what is maybe best for their child. So as I said, the prevalence of myopia is very high. In the United States, 1 out of every 3 people has myopia. In some countries in East Asia, as many as 9 out of every 10 people have myopia. It's an extremely common disease. And I intentionally call it a disease because I believe that's what it is. It fits the definition of a disease almost perfectly. The definition of a disease is a problem with the structure or function, and in myopia the problem is that the length of the eye doesn't match up with the optics. So it's a problem of structure or function that leads to symptoms, and obviously the symptoms of myopia are blurred distance vision. And it's that's not caused, I should say, by trauma or injury. And we all know that we didn't fall down and become myopic one day. It happens sort of over time. So a lot of people think of myopia as just sort of a natural adaptation, but that's absolutely not true. It absolutely fits the definition of disease, and we should treat it as such. We should treat our patients, try to keep them from becoming as disease-laden as they would have otherwise. And I think the only way to do that right now is with myopia control. Even though it's a very high prevalence, the prevalence is actually on the rise. In the United States, just 30, 40 years ago, only 1 out of every 4 people had myopia, and now it's as prevalent as 1 out of every 3. And it's basically rising in epidemic proportions throughout the world. So it's something that I think we are becoming more and more concerned about as time goes on, and I think we as doctors should treat it as such. Our patients are concerned, we should be concerned, and we should do what we can to try and treat it appropriately. Interestingly, myopia costs the world $8.2 billion per year. To put that into perspective, if you talk about 8.2 billion seconds from right now, the year would actually be 2277. So that's a lot of money when you consider $8.2 billion. It doesn't sound like that much on a global scale, but when you sort of put it into perspective in terms of 8.2 billion seconds from now, the year will be 2277. I think that gives you an idea of just what a burden this is on society. Now, you know that the risk of sight-threatening problems increases with the increasing amounts of myopia. So if you have greater than 9 diopters of myopia, you're over 100 times more likely to have some sort of myopic maculopathy. But what you should keep in mind is that even people with lower amounts of myopia still are still at risk of this myopic maculopathy or vision loss. So when you consider people with less than 5 diopters of myopia, Ian Flitcroft actually did a calculation, and because those people are much more prevalent, those with less than 5 diopters are much more prevalent than those with over 5 diopters, approximately 43% of myopic maculopathy is actually associated with people with lower amounts of myopia. So it's a common problem, and it's a problem that causes sight-threatening vision problems, and we should do whatever we can to try and put people at lower risk of those sight-threatening vision problems, even if they are ultimately destined to only be low to moderate myopes. So as I said at the end of this lecture, what I hope you will be able to do is talk to parents about myopia control, because as I said, they have a lot of information available to them. So it's almost just like they have enough information to be scary, but not enough information to be smart. So they may think that they know the answers, but really only you can provide the answers, and I hope that's what we'll be able to impart to you today. We want you to understand a little bit about how myopia progression is slowed, because then you can take that information and put it into effect in your own clinics. So if we know some ideas about how we might actually optimize myopia control, you can try and put them into effect and see what you can do for your patients. And we want you to understand how to maximize myopia control, and you can do that sort of by knowing a little bit more about how the progression slowed. So that's what we hope to be able to do today, and I hope you take away from this. Let's talk about what is clinically meaningful myopia progression. In order to do that, we sort of have to make a few assumptions about myopia progression. Some of them are better than others. The first assumption, I think, is a very good one. In the United States, the progression of myopia is about a half diopter per year. And we know that that is found in study after study. If you look at the control groups, half to maybe up to 3/4 of a diopter per year progression is very standard. Most children become myopic around age 8, 9, or 10, and they tend to progress until about age 15 or 16. So I think those are pretty good numbers, but we know there's a lot of variability around that. For example, I became myopic when I was 16 and progressed through age 20, 22, and then slowly thereafter. So there's a lot of variability, but I think it's safe to assume most children sort of tend to become myopic at about age 8 and progress through about age 16. We typically diagnose myopia at about 1 diopter. We rarely diagnose and especially don't treat myopia at minus 0.12. So I think a good beginning point is -1. If a person begins as a -1 myope the first time we detect it at age 8 and they progress at a half diopter per year until age 16, that person would end up as a 5 diopter myope. So with those assumptions in place, if we have a treatment that reduces myopia progression by 25%, a patient would end up as a -4 myope. If we have a 50% reduction in terms of myopia progression, the patient ends up as a 3 diopter myope. And if we're able to completely stop it, obviously that patient remains as a 1 diopter myope throughout the myopia progression period. With those in mind, I frequently ask at various lectures what people think is sort of a clinically meaningful slowing of myopia progression. There are a few people who think 25% is. Almost everybody raises their hand at 50% reduction in myopia progression, and there are just a few again who don't think it's even clinically meaningful until 75%, or maybe even stopping it. Maybe even preventing it is the only way that might be clinically meaningful in some people's mind. But we're going to keep in mind sort of that 50% reduction in terms of myopia progression when we consider what myopia control treatments might be effective for our patients. So this is a summary of the literature. When I look at different studies, I am finding all the different studies where we have an experimental treatment and a control group. So we have a comparison in that particular study. So that's what all these various studies are. I've combined them by treatment type, so whether it's atropine, soft bifocal contact lenses, orthokeratology, or any of these others. And these bars indicate how much myopia progression is slowed by, or what percentage it's slowed by. If the bars point down, like they do over on the left, then that means that that treatment actually increased myopia progression. If the bars point up, that means that that study found that that treatment slowed myopia progression. And for example, if we look at the COMET-2 study, it slowed myopia progression by almost 25%. So that's the corresponding sort of percent slowing of myopia progression. I then just took the very simple mathematical average of each one of these. I didn't weight them in this particular slide at all. Just took the simple mathematical average to determine how much slowing was conducted by that particular type of treatment. So you can see that on average multifocal spectacles slow myopia progression by about 21%, whereas orthokeratology contact lenses and soft bifocal contact lenses are closer to 40%, and atropine is closer to about 75%. So you get an idea of the various treatments and how effective they might be in one picture.